Good morning. I would like to thank the organizers for having me. I'm Dr. Kenneth Cusi from the University of Florida, and I'm being asked in the next 10 minutes to explain to you why don't endocrinologists screen for non-alcoholic fatty liver disease as a complication of type 2 diabetes. So it's not a simple issue, but we'll try to cover it briefly and promote some discussion afterwards. These are my disclosures, largely for drugs that are in development. And diving into this, the key observation has been that people with type 2 diabetes tend to be at the highest risk of fibrosis and advanced fibrosis and cirrhosis. And as I like to say, this is a marriage gone sour in which each partner gets the worst out of the other one, because people with type 2 diabetes tend, as we mentioned, to have more of a risk of cirrhosis, more active steatohepatitis, and also people with type 2 diabetes have been found for now decades in epidemiological studies to have a higher risk of hepatocellular carcinoma. On the other hand, when we see in our clinic people with diabetes with NASH, they tend to have more dyslipidemia, more metabolic risk factors, and be more difficult to treat. In that context, I just wanted to share with you a typical patient, a 53-year-old man with diabetes. They have a number of comorbidities, and keep that in mind because that is one of the factors that limits and distracts the attention from NAFLD of us as endocrinologists. We have to take care of a number of problems, as you see here: obesity, cardiovascular disease, this patient has chronic kidney disease, stage 3, hypertension, dyslipidemia, sleep apnea, and low testosterone levels. So we have to address all these issues in a follow-up that in the United States is scheduled every 20 minutes. In this person, also, there's a history of liver disease. That's something that should bring the attention to the clinician. And you see that also that the patient is obese, has an uncontrolled diabetes, elevated liver enzymes, and atherogenic dyslipidemia. In this complicated context, endocrinologists now are asked to find out if the person has fatty liver disease, but more importantly, if the patient has a risk of having clinically significant fibrosis, and when do they have to refer to the specialist. So let me go over this, and there's been progress, although changes in management and behavior by doctors are slow to happen. I mean, I think a key aspect was when in 2019, and now, of course, in the current 2022 standards, the recommendation was made that people with diabetes and elevated liver enzymes or a fatty liver on ultrasound that we can find from electronic medical records should be evaluated for NASH and fibrosis. This is a big step forward. However, it has been slow to embrace for a number of reasons. Among them, I think it also falls short because most of the patients that we have with fatty liver disease do not have elevated liver enzymes. So that is something to keep in mind, and why I think we should do systematic screening of our patients. This is a study that we did in 561 patients with type 2 diabetes and published in February of 2021. You see that about 1 out of 5 patients has fibrosis, some degree of fibrosis by elastography, but very few have elevated liver enzymes. And when we look a little bit closer, we see that about 15%, 1 out of 6, has what we would consider like F2 and F4. And we were able to biopsy about a third of the patients and confirming the findings. So again, liver fibrosis is not frequently associated with elevated liver enzymes above 40. Now, using lower cutoffs would be probably a solution, but still has not been embraced in a consensus. This is a very other interesting study we published in 2021, looking again, trying to separate diabetes from obesity in people without diabetes. And as you see in the overweight range, about half of the people with diabetes already have fatty liver using the USFLI. And if you go further into the obesity range, by the time that you have a BMI of 35, almost all people with diabetes have steatosis. And again, going up in people without diabetes and obesity as well. Now, the key thing is fibrosis. If you look at the traditional cutoff of 2.67 for FIB4, we see between 6 to 10% of individuals with diabetes have that higher cutoff, which would represent having F3 or F4, about half if you don't have diabetes. But if you take an intermediate cutoff of 1.67, that probably enriches it in F2 as well. It's 1 out of 5. So it's a high percentage of our patients with diabetes. The other aspect that we don't have a lot of time to discuss is that another big implication is that most people with NAFLD, whether they have fibrosis or not, have higher risk of cardiovascular disease. And I think this is something that also is important because it helps us identify those people with diabetes with higher risk. So specifically, why still there's some lag in our attention as endocrinologists into this? One, there's unawareness. I still have some peers say, well, I've never saw somebody with ascites in my clinic. I think that happens because they just go from the hepatologist to the hospital for a decompensation and back to the hepatologist, and they skip the endocrinologist when they're very sick. Guidelines have not been placed yet to put enough emphasis. I think the ADA will change the guidelines to embrace more universal screening with FIB4. We have recently completed the American Association for Clinical Endocrinologists guideline, and with collaboration with ASLD, and hopefully this will have an impact. As I said, our patients with diabetes already have 5 or 6 medical problems to take care, and it is a bit overwhelming to add another problem, but that doesn't mean that we will not do it in the future. We don't have a great test yet for steatohepatitis or for fibrosis. FIB4 is okay, but has limitations that all of you are fully aware. And again, it's difficult for us as endocrinologists to shift from metabolic disorders to a liver disease. And we've not been very good at paying attention to liver enzymes unless they're very elevated. So I think changing that mindset to go first to a FIB4 test and later an elastography test or biomarker is going to take a little bit of time, but you know, we've done some work in this respect. So the key thing is for us to screen people for NAFLD in the same way that we do it for diabetic nephropathy or retinopathy. This person, for example, has a FIB4 of 2.2, puts it in the gray zone. So this calls then, and we did an elastography test, confirming steatosis and level of stiffness that would be in the F1, F2 range. And that's why we, with Dr. Canwell, who's a leader in the American Gastroenterological Association, Dr. Shobrook, who's a primary care doctor, a number of leaders in the liver and diabetes and obesity fields came up with these guidelines that will encourage doctors to order a FIB4, which allows them to at least half of the people with diabetes fall into the low risk. And then those who fall in the gray zone as our patient or high risk would eventually be evaluated with a second test. At the time of this, ELF was not approved in the United States, but I do think that elastography would be the best second test. But again, also assisted by other proprietary biomarkers like ELF that has a good outcome data, ProC3, which is now getting into a more broader and commercial platform, or NIS4 and others. And then this would help guide the management, divided into low risk, in which primarily the primary care, dietitian, endocrinologist, cardiologist, obesity management person would be involved with. The high risk on the other end, eventually with clear cutoffs and non-invasive tests, eventually with a liver biopsy. would be managed by the hepatologist in a multidisciplinary, and then those intermediate, indeterminate, or intermediate or gray zone patients, many not willing to get a liver biopsy with intermediate values, again, also worked up and managed by a multidisciplinary team with a hepatologist. The key message here is that we do have, again, the need to consider weight loss if overweight or obese, cardiovascular risk reduction, keep the patient on a statin, and we have diabetes medications that work. Both are underutilized for different reasons. Pioglitazone has ample evidence in people with and without diabetes. I think this audience is already aware of that. So to finish, our patient had significant risk factors, a biopsy that confirmed NASH. We put the patient on semaglutide and pioglitazone, and also a statin, very important. And the patient reached goals in terms of almost goals with A1C and frank reductions in liver enzymes. Take-home message is, I think, where we're going to be in 2022 is to incorporate the liver in the same way we do for renal and cardiovascular disease, and we have agents in the diabetes field that can work. The second step, I hope that the ADA in 2022 will incorporate NASH as another subgroup that should be managed differently. To end, I'm going to just finish with a few thoughts. Number one, I hope that the education that is going out for primary care and endocrinologists will lead to systematic screening of all patients with type 2 diabetes, because they have increased morbidity and mortality. Still, I have to admit there's significant inertia, but the calls to action from meetings like this, the job, excellent work that Dr. Lazarus and many of you in this international effort are helping to spearhead a change in our treatment paradigm. And the take-home message, there are things we can do today while we await the drugs that are under development to be approved by regulatory agencies: lifestyle, weight loss agents, metabolic surgery, and diabetes medications. Talking about screening for people with diabetes, screening is always important to be linked to an option for therapy. The cheap option would be pioglitazone, like the metformin for NASH. It's basically very inexpensive in the United States and most of the world. Semaglutide has shown the effects that I mentioned earlier. Other GLP-1 receptor agonists probably will be beneficial in the proportional to weight loss. And then SGLT2 inhibitors, although we don't have histological outcomes. So with that, we are waiting the new agents to become available. And I'll just stop here. Thank you very much. I'll introduce you to our group in Florida. Please come visit us soon when COVID allows. Thank you for your time.